move the screen share.
Ooh, I see the attendees. Everybody's coming in. How
Okay.
exciting. How exciting. I see a chat and hello.
It's 12:01. Shall we just start it?
Oh no, just we'll give them a minute because the attendees are going up.
Yep, and as a reminder to everybody, if you want to chat with all the attendees, make sure that you check in that drop-down list to send your message to all panelists and attendees. Otherwise, only the three of us are going to see it.
Mm-hmm. Perfect. Look at everybody.
Brandon, I really appreciate you being here because what I think came up in another webinar was on that it's always good to have an IT person in the background to deal with issues along the way.
Yeah, no problem. And also to that point, actually, it looks like you're maybe getting a little bit of like latency from your internet connection. So if it keeps stuttering for you, I would maybe just turn off your camera, and that might give you enough internet bandwidth to keep going.
Okay. Stop video for me.
Yeah, I would recommend doing that. So when you share your screen, it's
Okay.
not going to eat up all
All right, good. That.
Perfect. Perfect. Everybody.
Okay, got 60.
Everybody's.
I think, what did we have registered? About 80?
Yeah, we'll just give people a little bit more time, not too much time, but we're just going to welcome everybody, and we're talking to make sure everybody can hear our sound and let you know that everybody is muted for this webinar, because this is in a webinar format rather than your regular Zoom. So thank you so much, Mr. Brandon and Ms. Robin, for hosting this webinar for us. If you have any questions throughout the presentation, please feel free to use your chat feature. I will be checking that very, very often, and we'll try to answer questions real time. We also will have time at the end for a Q&A session, so please keep the questions coming. There are CEs available for this, so everybody will be getting 2 CE hours for this webinar, so that's exciting. If you are a GATRA member, that means you have 2 free CEs, and if you are not a GATRA member, then you only had to pay a very small fee to get these 2 CE hours. They are not category A, but I promise you that this is going to be an amazing, amazing webinar. If you want to, under the chat, there are there's like a drop down. So you'll see there's a blue bar and there's a drop down. You'll see where it says all panelists. So that means that the 3 people that you see on the screen will be getting this message. If you want the panelists and your colleagues to be able to see your question, you can do it to all panelists and attendees, or you can do us individually, which I do not personally recommend. So that way we can see your questions as they come in. Shameless plug. Our virtual conference in November is shaping up very nicely, and we're excited to be able to offer that the very first week in November. So it'll be November 2nd through the 6th. And if I butchered those dates, please forgive me, but I do know it is the very first week in November. So stay tuned. The Education Committee is working very hard with this. We actually have some national speakers that will be in attendance for this conference, so we're really excited. And that's really all I had today. And again, thank you so much for attending. If you are attending only by phone, I recommend that you join in as well, because we will be taking quote unquote attendance based off of your login. So please make sure at least there's some way that I can identify who you are so we can log you in. And that way, if you get audited by NCRA, we have proof that you were able to log in. So without further ado, Ms. Robin, if you want to get us started.
Yes, good afternoon. Thank you for joining. I'm sorry you couldn't see my face, but our IT guru, Brandon, said my internet was a little unstable, so that it would be better if I turned my camera off. So the first thing that we're going to do is give some background information on COVID-19 with our nurse practitioner expert, Dr. Anagha Cupples. She could not be here with us today, so Debbie Chambers and Ronda and I sat down with her a couple of Sundays ago, and we recorded a video on Zoom that we just thought was so informative. So we're excited to share that with you today. So without further ado, here is our interview with Dr. Cupples.
This one is going to be on COVID-19 and how we are going to be abstracting the information that is needed. But of course, in order to be able to be a better abstractor, we have to know what it is that we are abstracting. So we have the lovely, the talented, the fabulous Dr. Anagha Cupples. She has been a CTR for close to 14 years. Of course, she has been a part of the Georgia Center for Cancer Statistics, better known to us as GCCS, for upwards up to close to 20 years. I want to say, if I do the calculations correctly, it's 17 years. But most importantly, the reason that she is our honored guest today is because she is a nurse. And not only a nurse, a doctor nurse as of last year. So Dr. Cupples is a motivated family nurse practitioner dedicated to providing the best patient care through interprofessional collaboration, active listening, and motivational interviewing. Her goal is to implement the Institute for Healthcare Improvement's triple aim, triple meaning three, right? 1, 2, 3. What's the first one? Improving patient care, improving population health, and then, of course, reducing costs. So Dr. Cupples is here to give us her expertise and her medical experience with working with COVID. So thank you, Ms. Dr. Cupples, for joining us today.
Thank you so much, Rhonda. Appreciate being here. Thank you for inviting me.
Yes, thank you. So we're going to go right on into it. So hopefully everybody has muted their phones and muted themselves, so that way we don't hear any background noise. However, if you hear something on my end, that's just because a future GATRA member wants to make her appearance. So let's get right to it. So what is COVID? What is the coronavirus? What are the first symptoms of this? And when should you get tested? Let's just get right into it.
That's a great question, Rhonda. So before we start on symptoms, let me just say something. Coronaviruses are not really new, okay? They have been around for years and years. They cause mild illnesses like the common cold. And now COVID-19 is a new coronavirus that has never been seen before, hence the name novel corona. The virus that causes COVID-19 is the SARS-CoV-2 virus. SARS stands for Severe Acute Respiratory Syndrome Coronavirus 2. This name was chosen because the virus is genetically related to the coronavirus responsible for the SARS outbreak of 2003. But while they're related, the two viruses are different. Now to answer your question, there's no single symptom, and no single symptom is going to be the same for everyone. The symptoms can include fever, dry cough, shortness of breath, headaches, sore throats, myalgias, and in some people, diarrhea or GI issues. So after talking to many people, one of the first symptoms in a lot of people seem to be a loss of smell and or a loss of taste. And most people get tested if they have symptoms or have been around people with symptoms.
Wow, that is so interesting. So GI symptoms and losing my smell?
Yep, losing your sense of smell, and because you lose your sense of smell, you lose your sense of taste.
Wow, so that means that if I know somebody is cooking some collard greens and I can't smell it, and then I try to taste, them collard greens and I can't taste it, that might be a first symptom, especially if I feel like I've been exposed to somebody that has this virus.
Exactly.
Wow. Okay, so you mentioned that symptoms that you get tested. So in the news, we have heard that there are different tests. There's a viral test, and then there's an antibody test, and then there's a test that they try to tickle your brain up here with your sinuses. Like, I know that's got to be one of these tests. So can you discuss the tests and what it means to be positive or negative, or take it?
Yes. So I'll do my best to do that. So generally, there are 3 types of tests.
There's
the
3.
Antigen test is the rapid diagnosis test where you can potentially get your results within an hour or so. And now all of this is generally speaking, because if the labs are backed up, then it's obviously going to be more than an hour, more than a couple of days. The general time when you are supposed to get your results may not always be the general time. So that's first, the antigen test or the rapid test, where you can get your results within an hour. The molecular test, or the PCR test, can take anywhere from 24 to 48 hours. But like I said, it's kind of taking longer because more people are testing and the labs are backed up. So it's probably going on right now 10 days before you get your results.
Wow.
The serologic tests, which are done by blood draws, those are the antibody tests, and those can take between 24 and 72 hours. Sometimes a second antibody test is needed for accurate results, which is why the jury is kind of still out on antibody testing. And we'll go over later why the jury is still out on antibody testing, because it's not always an accurate measure. The molecular PCR or polymerase chain test is thus far the most accurate.
Okay, so how do you know, just listening in on what you're saying, so the PCR test is probably the one that's the most accurate, when this is done, can testing be done both on those that are symptomatic and asymptomatic?
Absolutely. So for the viral test, the PCR test, yes, they can be done on both the asymptomatic as well as the symptomatic. And it's very surprising to us because, on the one hand, you have people who are dying of COVID, and on the other hand, you have people who have absolutely no symptoms walking around in public. And it's that the two sides are so vast. There's no symptoms, and then there's symptoms that can cause you to pretty much die. So.
Right. So under what circumstances other than symptoms, or is that really the only circumstance, under your opinion, that the PCR tests are administered?
So people do test for various reasons. Sometimes their employers want them to test. Sometimes they've been around people who have been COVID positive, so they would like to know themselves. And then some people just want to know for themselves, do I have it or not? So those would be the reasons why they would want or do test.
Okay, perfect. So if I remember correctly, reading your very, very impressive CV, you have done some work in the community giving out these tests, correct?
Correct.
Okay, so can you kind of just go through what your experience has been in giving people these tests and anything around that as far as what you've done in the community?
Sure. So what we did was, in the beginning, I did some spot testing, meaning specimen point of collection. I was actually working with the Gwinnett Newton Rockdale Health Department to be able to do that. It was very interesting because people used to come through drive-through or walking and they needed a test. Well, we kind of turned away people from the walking because we didn't want to be exposed ourselves, but the people who were drive-through, we did test them. Now, initially, when the test first came out, we had to do a nasopharyngeal swab, which is very difficult to do, and your head has to be at a certain angle, and it's very uncomfortable, really, for both parties, because you're bending over, you're trying to make sure that the person's head is a certain angle, and that's where you were trying to tickle your brain, literally. Yeah, but now the PCR testings are better because now they're only nasal swabs, and you can pretty much self-swab. So you don't have to wait for somebody to tickle your brain. You can do it yourself, basically. But the nasopharyngeal swabs were the ones that had to go a certain degree, and you had to get it a certain way. But the nasal swabs, they're much easier, and you just do 10 seconds in one nostril, 10 seconds in the other nostril, and you can self-swab. So the funny part was when you drew tears in someone, we said you hit the right spot. So that's how that goes.
Yeah, I have not had the pleasure of experiencing one of those tickle up here type of tests, but those that have told me the experience, and I am so glad that you said that they have there's newer tests that are less that are a little bit more fun.
Yes, much better.
Yes.
I would rather do the nasal swab than the nasopharyngeal.
Yes, absolutely. So now that we've kind of gone into the type of test, let's talk about the other part of it, which is, what do these tests mean? So what does a positive and a negative result actually mean? And is there a difference between a positive and a negative result depending on which tests that you actually did?
So that's a great question. But before we talk about positive and negative, let's just talk about the viral test and what it actually is. I kind of gave you some information about what we do to get the sample, but what it's kind of like, if you've ever been tested for the flu, it's pretty much like that. So with the flu, we would do the same thing with the swab, and that's pretty much the easy part, the self swab, or it's kind of just like the flu test. So the positive and negative results, it's kind of really not that simple. When you get your report,
Of course.
would it ever be that simple?
Can it be that simple?
Well, you get your report, the results come back with the results can come back with a positive, a presumptive positive, or a negative, or an invalid. Okay, so there's four types of things that you can have. When the results come back positive, it will show up as a COV-2 RT-PCR, which is the actual test, the PCR test, and it will say detected or abnormal. which means you're positive. Okay?
Mm-hmm.
If it shows up as a presumptive positive,
Mm-hmm.
you most likely have it, but it is unclear. So you should get a confirmatory test to make sure. But if your report does say that you're presumptive positive, we're going to treat you the same way as if you were positive. Okay?
Okay.
Now, the negative can be good news, and I say quote unquote can be because it depends on when you test. Okay, so in other words, if you test too soon, you might show up as a false negative. So the incubation period generally of COVID is between 7 to 10 days. So if you test, say maybe on day 2, it might still not show up as positive, even though you may potentially be positive. Okay, so the negative on your lab report just shows that your COVID was not found in your sample. And that also means very little, because if you self-swabbed and did a poor job of getting the sample, you might also be considered, or the test might show you as a false negative. And then, of course, there's the invalid result, meaning something either went wrong with you collecting the sample, something went wrong between you sending the sample to the lab, or something was not right and you definitely need to retest to get a confirmation test.
Wow, that's so interesting. So never even occurred to me that a sampling error could potentially give you a result that could potentially be a false narrative.
Absolutely.
Wow. Wow. That's, see, this is exactly why we had you. Not only are you a fantastic nurse practitioner, doctor nurse practitioner, but you also see it from our side as being CTRs and how it's going to be, you have to do a little bit more research into the EMR to be able to get the information that needs to be extracted into the abstract, to where that's going to be part 2 of what we're doing, is exactly how do we abstract this information. So thank you. This is, selfishly, I can say that this has been extremely, extremely helpful.
Absolutely, my pleasure. You are too kind, Rhonda. But I did want to talk about antibody testing also.
Yeah, that's actually pretty cool, because somebody just sent in a question saying, okay, so she just gave us the information about the viral. What about the antibodies? So great segue. Look at that. Go ahead, please.
Okay, so antibody tests, they actually check your blood by looking for antibodies, which tells us if you've had a past infection with the virus that causes COVID-19. So antibodies are actually proteins that help fight off infections and can provide protection against getting that disease again, just like chickenpox or whatever. Antibodies are very disease specific. So unless the viral testing is delayed due to availability, we would never recommend you do antibody testing before you do antiviral testing. That's just not a good situation, because again, like I said, the jury's out on antibody testing, and I will tell you why that is in a second. So it takes your body almost 1 to 3 weeks after infection for your body to make the antibodies here, but there are 2 types of antibodies, the IgG and the IgM. The IgM is what your body is going to show around 2 to 3 weeks. It could be 2 to 4 weeks too, after your infection. And the IgG shows up like around 4 weeks to after 4 weeks. So like I said, to recap, if you have a current infection or feel like you've been exposed to someone who is infected, it's best to get a viral test because those are more accurate. The caveat again is that it depends on when you get tested, because if you don't get tested at the right time, you could show up as falsely positive. Clear as mud?
You know what? It is clear as Georgia clay. But the thing is, I for one believe that this totally makes sense. And the fact of the matter is the difference between the viral and the antibody, and doing the viral testing first makes more sense than doing the antibody test, especially seeing that that is still being, I don't want to say developed. What's the word I'm looking for?
I guess perfected would be the word.
Yeah, I think that is a great word for it. Absolutely.
So let me tell you why we think that the jury is still out on the antibody testing.
Yeah,
so a lot of things that's unclear to us about the serologic testing. From what we know, antibody testing is done 1 to 3 weeks after infection. And if the antibody test is positive, then yes, most likely you've had the disease at some point, whether you were symptomatic or asymptomatic. But the jury's out on antibody testing because some research has shown that if someone has had a type of coronavirus in the past, because like I said, coronavirus is not new, this one is new, then it can show up as positive. So we don't know if it's positive for previous coronaviruses or if it's positive for this particular coronavirus. That's what makes it so unclear.
No, that's that totally makes sense. So if I can summarize again, let's give an example. So say, a lot of us, or those that, our loved ones, sometimes we have to be tested as a requirement to participate in activities, whether it's sports, whether it's returning to work. Some churches are having people be tested. So in your opinion, your expert opinion, your medical opinion, the type of test that we would get would be the viral test, which is the PCR test.
Correct. Absolutely correct. Excellent summarization.
Yay! See, I'm listening. I'm paying attention, and that's perfect. All right. So this question just came in, and this is actually a really good one. So say that you did the viral test, and your viral test actually came back positive. So although this doesn't have anything to do with our CTR work, but this is more so being because we are people and we could be potential patients. Now that we have a positive test, what are the next steps?
Okay, so once a patient tests positive, the CDC has several recommendations that they ask you to follow. Mm-hmm. And first of all, being once you've been exposed or you have symptoms, you definitely need to isolate yourself in some corner of your house, your room, whatever. And you should isolate at home for 10 days. So again, if you have a positive result on your viral test or a presumptive positive on your viral test, we would tell you to do the same thing because you are presumed positive until proven otherwise. Okay? So you would definitely want to isolate yourself for 10 days. This is to ensure that you're no longer actively infected. The isolation is where you are avoiding spreading the infection to, which is why I think asymptomatic people are more dangerous because they don't have any symptoms. They are out in the community. They have nothing to want to go test themselves for. And if they're younger, then they might think, well, I can just handle this, or however that works. Mm-hmm. You should definitely, if you've been exposed, want to test yourself. And even if you tested negative at one point in time and later begin developing symptoms again, I think it would be a good idea for you to get retested just in case you can isolate yourself, or some jobs even are dependent on that. The things to do If your employees are sick, are to tell them to stay home, except to get medical care. If they have trouble breathing or some sort of emergency, they definitely need to go to the hospital. And they should inform their supervisor if they have a sick family member at home, because they don't want to come in and infect other people. Definitely want to advise them to wash their hands for 20 seconds or to use hand sanitizer, which has at least 60% alcohol. Soap and water are almost always awesome, because while the alcohol sanitizer may, yes, that's exactly right. But, you know, shops and places are running out of those sanitizers. So the best thing to do is wash your hands. Like, you always get soap and water available to you. And inform the employees that if their hands are visibly dirty, they should definitely use soap and water. Some things are common sense, but we have to tell people anyway, just in case it's not. So before you want to clean sanitize your hands, and maybe even clean your workstation before and after your shift, before and after work breaks, after blowing their nose, coughing, sneezing, after using the restroom, before, after putting on or touching, there you go, after putting on your face masks, and try not to touch your eyes, nose, mouth, anything that has mucous membranes. Also cover your nose and mouth with a tissue when you cough or sneeze, or put, you know, in the crook of your arm or elbow, and then throw those tissues in a no-touch trash can if you can, and immediately wash and sanitize your hands. So if you can practice routine cleaning, disinfection of things that you touch every day, like your doorknob, your keyboards, your mouse, your computer, just things you touch on an everyday basis that you don't even think about. Just, you know, that would be very helpful. Handrails, doorknobs, of course, desks, those kind of things. And then stay 6 feet apart and do your social distancing, just like we've been doing, and just like the CTRs have been doing. Let me just say.
Yes. And one thing that I've heard also, just like how you said, like just common things that you touch that you don't even think about doing, your cell phone. This goes everywhere, like doing your cell phone as well. Like yeah, of course.
Absolutely. That's something you touch every day.
It is. Okay, so thank you for allowing me to have you shift to us being patient. So now let's go back. And I am cognizant of time, because your time is valuable, and I want to make sure that we get these questions answered. Let's shift back to the CTR world and statistics.
Sure.
So is there an area in Georgia where there are more cases seen? Like, how does, statistically speaking, how does it look in Georgia?
So there are places, to answer your question, yes, there's more places that are seeing a rise in COVID, probably because they have more testing. And the positive cases can be counted twice, because if someone tested positive and then 2 weeks later they decided to come again and see if they were negative but still turned out positive, it would still be counted as positive, but not as a new case, if that makes sense.
It does.
There is actually the counties that we are seeing that has the most, Fulton actually is leading. Fulton County is leading with 23,622 positive cases. Gwinnett is 22,991. This is as of 8/23/2020. DeKalb is 15,860 and Cobb is 15,816. Currently, there are 252,222 confirmed cases. Again, like I said, the positives are being counted again, but they are not necessarily new cases. There have been 5,092 deaths in Georgia, 23,325 hospitalizations, and 4,251 ICU admissions thus far. And it could be because, like I said, we are either testing more or the fact that caregivers and people are living in congregate settings. So that could be another issue because they're living in congregate settings, and if they turn out to be asymptomatic and not necessarily going to test, that's how they're spreading. So that could be one of the reasons. But generally, you know, unfortunately, COVID is affecting African Americans and minorities disproportionately. And we are also seeing more confirmed cases among women than men, probably because women are caregivers and,
yeah,
you know, so.
Yeah, no, there's definitely, wow, that is a lot more than I thought. So thank you so much for sharing those numbers.
Sure, and I think the hardest hit age, which is just shocking, the hardest hit age has been 18 to 29-year-olds, unfortunately.
Really?
Yeah.
You said 18 to 29?
Yes, the very young people.
Wow. They don't talk about them in the news like that.
Right.
Wow. Wow. That's all right. All of us young people. Yes, I'm going to consider myself to be in that. No, I'm not in that group anymore. Darn it. But we all know somebody that knows somebody that have people in that age group. So it is not just targeting those that have comorbidities or that they're in the quote unquote golden ager population, but this younger population is also being targeted hard as well. That's incredible. Thank you.
Very shocking.
So Debbie submitted a question. So thank you so much for this, Debbie. Any news on a vaccine for this?
So here is the good news about the vaccine. The whole world is working on this vaccine. Yes. Around the clock too. So that's good news. Mm-hmm. I mean, some scientists are looking at potential treatments and a vaccine, and some are actually working on antivirals, which are already being used to treat other illnesses. So generally vaccines have to go through at least three phases before it is available to general public. Sure. The first phase is usually like given to a small number of people. The second phase is given to hundreds of people split into groups, mostly immunocompromised, to see if the vaccine acts any differently in them. And the third phase is when the vaccine is available to thousands of people. And so the coronavirus vaccines, some of those vaccines are now in phase 2 or 3 trials. Wow. And some can have combined phases too. So some companies are actually combining phase 2 and phase 3 all in one. Mm-hmm. And they are testing them first time on hundreds of people. As of July 27, Moderna, along with National Institutes of Health, are also launched phase 3 trials. So has BioNTech, along with Pfizer. So to answer your question, we're not sure yet where we are on the vaccine front. Last I heard, I believe they said that we might have a vaccine next year in the first quarter.
Wow.
But that could change. That could change.
Yeah, about to say, as of today in August, that definitely could change, because it seems like the more data that comes in, and of course, the more information that we have, we're able to make better decisions. So that is not surprising, but it is great to know that the world is working on it.
Yeah.
So that's awesome. Of course, we have to close. God, this has been such a great interview. Again, Dr. Cupples, thank you so much for doing this for all of us here at GATRA. In your personal, professional opinion, where do you see the virus at the end of this year? Well,
we hope that it's contained, but we're actually more worried because people with comorbidities were already susceptible to the flu virus. And now we have COVID to deal with on top of everything else. Mm-hmm. So not that I'm trying to invent new words or anything, but we are very worried about fluvid this fall, okay? Mm-hmm. The flu and the COVID combination. So I am worried. While I hope that this virus is contained, like I said, personally, I'm worried. As a healthcare provider, I'm worried.
Yeah, I can only imagine. And that is such a great term, fluvid. It will just stay between us.
Absolutely.
But if I hear that in the news, we know where that came from.
Absolutely. Love inventing terms.
Yes, that's awesome. Well, we are at time. And again, thank you so much, Dr. Cupples, for joining us and enlightening us and educating us on the coronavirus, the various tests, what these tests mean, the timing of taking whichever test, and the statistics within Georgia and where we see the vaccine coming, and your personal and professional opinion about the future and where we kind of see where this is leading to towards the end of the year. So,
absolutely, Rhonda. Thank you so much. It has been my honor and pleasure to be here. Thank you for having me.
Yes, thank you. And so now we are going to turn it over to Ms. Robin, who is going to give us the presentation on what this all means as we abstract the cases and we include COVID-19 information into the abstracts.
Thank you, Rhonda. And thank you, Dr. Cupples. We just thought that was an amazing interview. We hope everybody heard it okay. So now, what does that mean for us as CTRs? So now I'm going to take you through the instructions that SEER has passed along to us for capturing COVID-19 information in our abstracts. The first thing you might...
Robin,
yes.
I'm so sorry to do this to you. We are still seeing the Windows Media Player, so we do not see your slides right now.
Yeah, you may need to stop sharing and restart your sharing again. For the PowerPoint.
Do a new share?
Mm-hmm.
Okay.
And as she's doing that, please make sure, I've been trying to message people individually, but please make sure that your name is shown so that way we can clock you in for getting credit today. Thank you. Okay,
so everybody should see my PowerPoint presentation.
Correct.
You probably noticed from Anagha's interview some new nomenclature that you might not have heard or seen first in the news and the literature. The SARS-CoV-2, which is Severe Acute Respiratory Syndrome Coronavirus 2. That is the virus that causes the COVID-19 infection. The reason we are going to be collecting COVID-19 information is because it has a direct impact on outcomes. As of 8/10/20, the data that we have has shown that the incidence of COVID-19 in cancer patients is higher than in the general population. We have seen higher death rates in cancer patients with COVID-19, higher ICU admission rates, higher risk of complications. 8% of cancer patients had alterations in treatment plans due to COVID-19. This included options to postpone radiation and chemo to decrease the risk of COVID-19 infection. almost half of this 8% subset, treatment was indefinitely delayed or stopped entirely due to COVID-19. A new term you will hear, natural language processing. This is a computerized process for extracting information from text, and you will often hear it referred to as NLP. Sometimes you may hear it referred to as text mining. Now, because we have no currently defined coded NASER fields related to COVID-19, natural language processing will be used to extract information from text in the cancer abstract. The SEER COVID-19 abstraction guidance documents can be obtained from the SEER website. I sent out these slides in a Word resource document prior to the webinar. You can access the site directly from this link in the slide. If you don't have the slides handy, I'm going to show you how to navigate to that site. You all should be familiar with the SEER website. That's seer.cancer.gov. Once you get to their homepage, hover over Registry Operations, then over to Reporting Guidelines, and click on the arrow to the right of Reporting Guidelines. And then scroll all the way down and you will see the COVID-19 abstraction guidance. And so from there, you can access from a link within the body of that document, the COVID-19 abstraction guidance document, as well as a Q&A document. So this will provide all the instructions that I will be going over today in the PowerPoint. Abstraction of COVID-19 information will not, should not require changes to your usual case ascertainment or reportability rules. So you should not really change any of your processes in order to obtain this information. The information is required for all SEER registries, and there is no expectation that registrars seek medical documents beyond the sources that they currently routinely use for case finding and case abstraction. So what we have today are facility-specific instructions. There will be some central registry specific instructions to come out later. The text data items are applicable to cases diagnosed 1/1/20 or later and completed on or after June 1st, 2020. So what this means is if you have a cancer case diagnosed in 2019 and you have COVID information available in your medical record, you are not expected to capture that information in a 2019 diagnosis case. Additionally, if your case is diagnosed in 2020, if the abstraction complete date is prior to 6/1/20, you are not required to document COVID information in that abstract. They do not, SEER does not expect you to go back for cases that have a complete date prior to 6/1/20, cases that have already been submitted to the central registry. You're not expected to go back and update those abstracts with the COVID information as long as the completion date is prior to 6/1/20. The instructions provided will be for 8 text fields, and they are labs, remarks, surgery, radiation, radiation other, chemo, hormone, and BRM. Okay, once we get through the lab text instructions and the general treatment instructions, it will be kind of easy the rest of the way. But I have found that these instructions for lab text and general text are kind of the most difficult and confusing, and may take you more than one or two read-throughs of the instructions to really acquire a grasp of what you're collecting. So you will use the lab text field to record the date and results of your viral and antibody testing. And it must be collected in this format, as you see in the second bullet, COVID-19. And then within this first bracketed section, you would indicate the test type, whether it is viral or antibody. And then in this second bracketed section would be the interpretation, positive or negative. And in the last bracketed section would be your date in the format month, month, / day, day, / year, 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 year. You can copy and paste this format to a Word document that you keep in your own personal files. And I have provided a separate Word document that we will look at momentarily. You're going to record separately the viral nucleic acid testing, which is the viral test. Sorry about that. And the antibody test. The PCR and the RT-PCR tests are viral nucleic tests. Always record the interpretation and date of the latest, most recent positive antibody test. Do not record tests with unknown type. That is, if you don't know if it's a viral test or an antibody test, then you just wouldn't collect that information. Or tests with no interpretation or unknown interpretation. Record a partial date when interpretation is available and the date is not fully known. So you can record your month, year, or just the year. Do not estimate if the date is unknown. Code presumptive positive tests as confirmed. When you have multiple tests with interpretation, record the date of the first positive test when multiple interpretations are available for multiple viral tests. Record the interpretation and date of the last negative test when no positive tests are available, but one or multiple negative viral tests or one or more multiple negative antibody tests are documented. Record the last test for both when a negative viral test and a negative antibody test are documented for the same patient. Record the date of each negative test. So here are examples. This first example indicates that a patient had a COVID-19 viral test that was positive on 5/9/20. Our second example illustrates the patient was negative for the viral test on 3/9/20 and positive for the antibody test on 5/9/20. So that means even though the patient tested negative for the viral test, the patient would have had an infection previously in order to have tested positive for the antibody test. Or as Anagha mentioned in her interview, the patient could have been testing for a corona antibody that maybe was not the Corona-19 antibody. So this is why it's more important to rely on the accuracy of the viral tests. And then our last scenario, the patient was negative for the viral test on 3/9/20 and negative for the antibody test on 5/9/20. So what I have here, what I made up for everybody here, is what I call a Word resource document for abstractors. So this first item we have that you see, the COVID-19 with the test type in brackets and the interpretation in brackets and the date in brackets. If you like, you can copy and paste this right into your lab text field in your abstract, which I'll just do with a blank Word document. So you could copy that right into your lab text and then just superimpose over those bracketed areas. Like if you know that the patient had the viral test, and here you would just put in viral. And then if you knew, and then the test result was positive, you would superimpose here positive. And then the correct test date, say for example, it was today, you would put in 9/2/2020. Oops. Or if you wanted to, you could even copy and paste, you know, if one of these scenarios applied to your situation, copy and paste that, and then just superimpose the correct interpretation and date over the sample interpretation and date. So that way that's there for you, and it's in the exact format that SEER has requested. It's very important that you are collecting this information in the exact format as instructed by SEER in this documentation. Okay.
Hey,
Go.
Robin, if you were showing us your Word document, we were not seeing it.
Oh, you didn't see it?
Mm-mm.
Okay, so I guess I needed to do a separate, okay, let me go over that real quick so y'all can see that.
Mhm.
Okay. All right. Here is the Word document. So as I was explaining before, you can copy and paste this first example and superimpose over here over this black bracketed area. You can just superimpose that with the test type, viral or antibody. And then here over the bracketed area for your interpretation, just superimpose over that positive or negative, and then over here for your date. Or here are some scenarios that you could copy and paste, and then just be sure that you're replacing the example interpretation and date with your correct interpretation and date, as well as the test type, viral versus antibody. Okay, going back to the, okay. Well, here we go. Okay, moving on to the remarks text. You're going to record the applicable code and the associated date in this field. So this field is going to be where you indicate your confirmed diagnosis of COVID-19 as documented by a medical provider. You will record the code U07.1. Okay, and that is copied into that Word resource document. I'll show that to you again in a moment. This is the code that you will put in the remarks text if the patient has a confirmed diagnosis of COVID-19. Now, in this text field, you do not have to document the type of test because that would be captured in your lab's text. All you need for a confirmed diagnosis in order to use this code in this text field is physician documentation of confirmed diagnosis of COVID-19. So you would record the code U07.1 when the code was used for a diagnosis within the facility medical record, in the hospital discharge, or as a contributing or underlying cause of death. Record this code for a laboratory test confirmed for a patient who is asymptomatic. Record the date of a confirmed diagnosis. The test date is preferred, but if you do not have that, you can use the office visit date, the hospital admission date, or the hospital discharge date. And here you see an example, U07.1 on 5/9/20. Now you could copy and paste that into your abstract and just superimpose the correct date over this example date. Do not record, and that is in that Word resource document, but I won't go to that right now. I'll go to it in a few minutes when I'm showing you some other things. Do not record U07.1 when the provider documents suspected, possible, probable, or inconclusive, or any wording of a suspicion of COVID-19. Now, this is a little bit different from the lab text field, because if you get a lab test, if you get a viral test and it is presumed positive, then you are going to capture that as positive. But if you only have a provider statement that says the patient has suspected, possible, or any of these ambiguous terms here, that would not be diagnostic of COVID-19, and you would not in that situation code that U07.1 code. Registrars are not required to record codes for acute respiratory illness associated with COVID-19, for example, pneumonia. Now, this is also, this information here for general treatment, this is also captured in the remarks text field. It is preferable to capture any treatment information you have in relation to COVID-19 in the specific treatment fields, but sometimes you will only have information about treatment in general. So again, that will be captured in the remarks text. So you will record the information for all cancer patients when applicable, regardless of whether they have a COVID-19 diagnosis or a SARS-CoV-2 test. Now, what this means is there are cancer patients out there who do not have COVID-19, but their treatment plans may have been altered or delayed or discontinued because of the COVID-19 pandemic. So that is what you are capturing here. When first course of treatment was modified because of COVID-19 and no other specific details are provided in the treatment text fields, you will record FCOT, that stands for first course of treatment, change due to COVID-19. When diagnosis, staging, treatment, or other cancer management events have been delayed because of limited access to facilities or postponement of non-essential procedures due to COVID-19, document the date of decision to postpone and the Z75.3 code. So here is an example of that, Z75.3. on 8/18/2020. What that means was a decision was made to delay or discontinue or change a patient's procedure because of facility limitations. You can use both the FCOT statement and the Z75.3 code at the same time. This combination is required when multiple steps of cancer management were affected by unavailability or inaccessibility of oncology care. No recording is necessary if treatment was not delayed or impacted due to COVID-19. So moving forward in the rest of the slides, if the patient's treatment was not impacted at all by the COVID-19 pandemic, then you will not be capturing any COVID-19 information in that abstract. So I'm just gonna show you this Word resource document again here. So here are the items that you can copy and paste in your abstract for the remarks text. This U07.1 code, remember, is your confirmed diagnosis of COVID-19, and then it's captured in the month, the date of diagnosis of COVID-19. It's captured in this format. And here is an example. You may copy and paste that and just superimpose the correct date over the sample date. And then here are the examples that you can copy and paste into your abstract regarding treatment in general, the FCOT statement, and the Z75.3 code, which means the treatment was impacted somehow due to facility limitations. And here's an example that you can copy and paste and superimpose the correct date over the sample date. Okay, so now we're going to move on to the specific treatment fields. Our first field will be surgery. So you will record this again, like I said, for all cancer patients, regardless of whether they had a positive test or not. Typical surgery is recommended, was performed, but it was delayed due to COVID-19. You will record surgery treatment delay due to COVID-19. That will be in that Word resource document so you can copy and paste. Surgery treatment was recommended but administered after disease progression. Record surgery treatment delay due to COVID-19 and given as subsequent treatment after progression. And you will see that you'll be able to copy and paste that there as well. Type of surgery offered and performed was changed or modified from what is typically recommended. COVID-19, record surgery treatment changed due to COVID-19, or if the type of surgery offered and performed was changed or modified from what is typically recommended and it was delayed, you will record surgery treatment delayed and changed due to COVID-19. Or if the surgery was not performed due to COVID-19, record surgery treatment discontinued due to COVID-19. So you will again see that all of these selections are available to you in the Word resource document. And the nice thing about the rest of these treatment fields going forward is you're going to see a similar pattern of the statements that you will use. And the nice thing is no date. So you don't have to worry about a date. So you can copy and paste these statements directly into your abstract, and then you are assured that they are in the exact format that SEER has requested. Our next treatment field is going to be beam radiation. And that follows the same pattern as for surgery. I want to point out to you, EBRT, that means external beam, discontinued due to COVID-19. You will document that if the radiation was discontinued or if it was not performed at all. So this EBRT, discontinued due to COVID-19, is used for discontinued or not performed at all. So use that for both. Or if the EBRT, the radiation beam, was changed due to COVID-19, then you would document EBRT change due to COVID-19. If the treatment was delayed, you will document EBRT delay due to COVID-19. Or if it was recommended before but not given until after disease progression, EBRT delayed due to COVID-19 and given as subsequent treatment after progression. Our non-beam radiation, that's any radiation that is not external beam. So that's going to include your brachytherapy and your non-brachytherapy, which would be like your radioisotopes for thyroid or sometimes for liver. So this abbreviation, ICB, is for intracavitary brachytherapy, but is also includes interstitial brachytherapy. So your choices are following this similar pattern, but you're differentiating between intracavitary versus the other types of non-beam radiation. So if it's intracavitary and it was discontinued or not performed, you will document discontinued due to COVID-19. And then you will also use that same phraseology if not performed, or the other type of radiation discontinued. If the plan was changed, then you use this phraseology, change due to COVID-19 for either choice. You have the statement of when the treatment was delayed for intracavitary or non-intracavitary, delayed due to COVID-19, or if it was recommended but not given until after disease progression, then you have those statements that should start feeling kind of familiar to you as we go through the presentation.
So Robin, are you showing your presentation right now? Because we see the Word document.
Oh, sorry. I don't know what I would do without Rhonda, y'all. So hopefully y'all got all that. It's a very, moving forward, it's pretty basic where you're going to use the kind of same phraseology for each modality. And if you were staring at the Word document while I was going through all that, you probably saw that documented there, but we'll look at that one last time near the end. So let's go on to our next treatment modality, which would be chemo. So same format. If it was discontinued or not performed, discontinued due to COVID-19. If it was changed, for example, the patient's plan was changed from infusion to oral, chemo changed due to COVID-19. Or if it was delayed, chemo delayed due to COVID-19. Or if it was recommended but not administered until after disease progression, or was administered after disease progression, you record chemo delayed due to COVID-19 and given as treatment after progression. Same format for hormone. We have hormone discontinued or not initiated due to COVID-19, hormone change due to COVID-19, hormone delay due to COVID-19, or hormone was recommended but administered after disease progression, then there's your phrase there that you can see. Our next treatment modality is the biologic response modifier. So this is going to include the immunotherapy, and it also includes bone marrow transplants and stem cell procedures. So if the immunotherapy or bone marrow transplant or stem cell procedure was discontinued or not initiated, then you have the phrase discontinued due to COVID-19. If it was changed due to COVID-19. If it was delayed due to COVID-19, or when the immunotherapy or transplant procedure was recommended but administered after progression, then you have those phrases. So just showing you one last time the Word documentation, that it's available, all this phraseology is available for you to copy and paste into your abstract, no dates needed. So real simple for you to have on hand there to do that. And there's just all your selections there. And I provided that to you prior to the webinar, but if you need another copy, oops, I'm sorry. Didn't go back to the, now I'm getting the hang of it. Okay. You can email me a request if you would like another copy of that documentation. So that's all the instructions that we have for now. I wouldn't be surprised if we get some additional instructions later. I would like to acknowledge and thank Peggy Adamo at SEER. She's kind of the person in charge of this project, and I emailed her and asked her a lot of questions, and she was very kind and responsive and helped me a lot with this presentation. So at this time, I think we have about 10 to 15 minutes left that we can take some questions.
Yeah, absolutely. Thank you so much, Robin, for this. And we do have several questions. There's a common theme in one of the questions. And so it states, previously, we were not able to cut and paste from Word. So are you saying that we are now able to cut and paste from Word document? Yes. Are we allowed to now?
I would say, you know, I know that you've been instructed not to do that before, but I've seen a lot of abstracts come into the central registry where it's obvious that it's being done. So I kind of think you can. And particularly if you're not copying and pasting something that's a long drawn out, you know, like you're not copying a microscopic description from a path report or something like that. I think if it's something that's just, you know, 1 or 2 sentences, it should come through okay.
Okay, great. Next question is, this is coming from, God, that's okay. It says, patient with lung diagnosis delays surgery at D/T. That's due to, I'm assuming that's due to COVID. And interim decides to have stereotactic radiation instead. How to document this situation?
Well, you will capture that in the radiation and the surgery fields. So I would think, so the patient does not have surgery, so you're gonna use that discontinued where the surgery was not performed. And then you will document in the radiation field that the patient had radiation instead of surgery.
All right, thank you.
Because there was not an initial radiation plan that was changed. So I don't think that you would, I mean, you might just want to put in your text that the patient decided to have this in lieu of surgery, but I would say you would document that discontinued phrase for the surgery in the surgery text field.
Okay, perfect. Thank you so much. Another question that came in, so for all of these text fields, does it matter where the COVID text appears? First, last, etc.?
I don't think it matters as long as you are using that exact format for the wording, because that is what the natural language processing program will extract, is that wording. And I don't think it really matters if it's at the beginning of your text field or at the end, just as long as that is in there.
Okay, perfect. Thank you so much. Any other questions? We did have a couple of questions come in that are COVID specific, and so we are going to document those and send those back to Dr. Anagha Cupples to see if she will be able to answer those. And because I feel like she will be able to, we will send not only the question that was asked, but the answer as well to everybody that registered.
And if you would, please, I would like to collect the questions that were asked about the instructions, because Peggy at SEER wanted to know what questions were being asked.
Sure. We'll definitely do that. Okay, look at that. We have another question that just came in. At SEER Central, and I'm gonna read it verbatim. At SEER Central Registry, is the cause of death of going to be impacted due to COVID-19? And are we looking to be sure the patient died of their malignancy versus COVID-19? How is this expected?
From what I understand about death clearance, if the cancer diagnosis is in the cause of death or the secondary cause of death, we are going to look for an abstract for that. So I don't really think it matters if the cancer diagnosis is the primary cause of death or the secondary cause of death. If it's there, we're gonna look for an abstract. I hope that answered the question.
Yeah, and if it didn't, please, who submitted that, please do a follow-up.
Yeah.
But yes, for sure, I will definitely make a note of all of these questions and provide you with the list, Robin. Yes, thank you. Perfect. So I think that concludes this webinar. So everybody's going to be able to get some time back. Thank you so much for spending time today on this Wednesday, almost an hour and a half's worth. And hopefully that this webinar was super informative. A question that just came in, which I am going to get to, but thank you so much for reminding me. What's going to happen is that tomorrow, cross fingers, you will be getting a survey regarding this webinar. And so once you complete that survey, you should be getting another email that will have your certificate of attendance with the NCRA number and also the number of CEs that you were able to get. There you are. That you were able to get. So please, 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 this was our first Lunch and Learn of 2020. We are always looking for ways to improve. Thank you so much for everybody attending and being patient with us. We are definitely going to take some learnings back, so that way when our fall conference happens in November, again, the first week in November, then we will be able to be even more awesome than we were today. So thank you, Robin, for putting this presentation together. You guys are awesome. And if you see in the chat that I messaged you privately, please respond, because some people were showing up as numbers. And then some folks were showing up as even more funky names. So please look in the chat to see if you received something. If not, and you don't receive an email tomorrow, please reach out to myself or Debbie or Robin, and we will check into that. The survey will be coming from Eventzilla, as well as the certificate will come from Eventzilla.
Thank you, everybody, and thank you for my patience as I'm learning how to present in Zoom. Thank you, Rhonda and Brandon, for being here to help me with it. Really appreciate it, and I hope the information that we conveyed today is helpful, and hopefully if more information comes out, we'll find a way to get it out to you. Thanks, and have a great day, everybody.
Perfect. Oh, you did great. Let's